There are a lot of misconceptions about heart failure, and it cuts, unfortunately, in two different directions. On the one hand, when a person hears that they have heart failure, they think almost immediately it's a death sentence. And we know that with optimal guideline-directed medical therapy, that the risk for dying, the risk for events, let's say heart failure, hospitalization, or death, can be reduced dramatically through excellent medical and device therapy. So on the one hand, there's this appropriate fear of the diagnosis, and we tell our patients with good care, we can extend your event-free survival by more than 8 years with good medical therapy. On the other hand, it cuts in another direction, which is that often it is under-recognized that poorly treated heart failure has a mortality higher than most forms of cancer. So ultimately, it clarifies just how critically important it is to diagnose heart failure and adequately treat it. Because on the one hand, if we don't treat it well, we have a mortality rate worse than most cancers. But on the other hand, if we treat it well, we can reduce that risk dramatically.
I mean, you have a condition that is exceedingly common. It's one of the most common reasons people come to the hospital in the United States, especially our older patients. Yet we see such persistent gaps in the use of the proven therapies that we fortunately have, but unfortunately don't utilize. We did an analysis from a US outpatient registry a few years ago now. At that time, we only had 3 real class 1 classes of medication for our patients, and less than 1 in 4 eligible patients were getting any doses of a RAS inhibitor, beta blocker, and MRA therapy, those 3 classes of therapy. And then when you look at the actual target doses of these therapies, only 1% of eligible patients were actually simultaneously getting all 3 of those therapies at the guideline recommended target dose. At the same time, when you follow patients over visit after visit after visit in the outpatient setting, we see that there's very few medication changes made over time. We are essentially falling asleep at the wheel, I would argue, in most cases in the outpatient practice, where patients come in with robust blood pressures, robust kidney function even, yet they leave our office on stable sub-target doses or no medication at all in many cases. And I think we need to have a healthy respect for what heart failure is, and that even if the patient are feeling well today, they are not low risk. And how you feel today does not make you low risk, and we need to take heart failure seriously, treat it with a sense of urgency.